Hi, this is PJ Ewing from the Bees Knees Podcast. I'm your host, and I'm here recording this introduction on a lovely Saturday in Lower Manhattan. Just before I get going on making some carrot soup and some chicken for when the kids get home from their play dates. What a fun fall Saturday I've got. But before I get to my fun, I wanted to introduce a wonderful new person to our team at X10 Therapy, a physical therapist assistant named Candice Cawood. And I thought I was going to do just a little get to know you. Hey, Candice, tell us about yourself. And, you'll be lucky to have Candice as a coach if you end up with Candice, et cetera, et cetera. And it turns into 45 minutes of real insight into the history of recovery from knee surgery, as well as what the X10 is, how it affected Candice, and in fact, how she does coach and what the coaching process is like at X10 Therapy when we have a total knee patient or other knee surgery patient working with the X10 machine. So I was so excited after doing this recording with Candice that it struck me this morning that I'd better get that thing out there to share with you guys. So listen to my conversation with Candice Cawood as part of our Bees Knees podcast episodes. In this case, it's get to know a physical therapist assistant and understand a whole bunch of very valuable insight things about knee surgery recovery along the way. Here we go.
Welcome to the Bees Knees, a podcast full of articles, interviews, clinical studies, and advice about knee surgery, physical therapy, and life after knee surgery.
Hello, everyone. This is PJ. I'm here with Candice. Candice is an employee of X10. So you're going to get a chance to hear what life is like coaching and working with patients. And also, Candice, you're somebody who, I don't know, a year ago had never heard of the X10 or maybe a little longer. And now
Correct.
You're working with patients every day and working with the machine. And so it's kind of a neat opportunity to get to know you as a person. A lot of people that listen to this podcast will end up someday maybe on the X10, and you'll be their coach. So they're going to know about you.
Yay for you.
Right, yeah, you lucky future patient.
Yes, lucky future patients because I'm just so awesome.
Right. Well, that's why we're here, because you're so awesome.
That's right. So I should say hello, everybody.
Yeah. So, all right, well, let's do the thing then. This is your life, Candice. Take us through your background a little bit, and then maybe moving up to the time of hearing about this X10 thing.
Okie dokie. So I am a physical therapist assistant, and I have been, I kind of lose track, but I'm pretty sure it's been about 16 and a half years, and started on the journey because I wanted to work in the peds division, and very hard to get into. So that fell through, and I kind of landed in an outpatient and did that for 5 years before my mother-in-law, who's a nurse, got me wrapped up into the home care world, which I did not think that I would like, and I loved for 11 years. I love being in people's homes, love the connection that you get when you're at that level with somebody. And did that, and then made a move for my husband's job, and decided to take some time off to be at home with the kids who are a little bit older, and got bored. And I have a friend. We were in a wedding together, and her and I were chatting, and she was working. I'm like, well, she's also a PTA. I'm like, Erin, what are you doing? Like, what is this that you're doing? Tell me about it. And she's like, oh, it's this thing called the X10. And I'm like, I have no idea. And she's like, you haven't heard about it yet? And I'm like, no, I have no idea what you're talking about. She then proceeded to tell me about this amazing machine that she had come to be working with. And, I was like, Erin, what, you're like so excited about this machine. And she was like, no, you've got to look into it. You have to look into it. And so I did. And I wound up texting her back, and I was like, Erin, this thing is amazing. If there ever comes a moment where they need more coaches, like, let me know. I'm in. And that was
a fated phone call The
fated phone call. It did. It was. But I mean, it just was, looking into it, and I mean, there was other aspects that I liked about this too. But I mean, after watching it, and I will say, and I do. If you get a chance to become my patient, you'll hear me say this. But having come from the home care world, I've literally worked with probably every diagnosis that you can imagine that you would be well enough to be home for, but not well enough to be out in the community for, right? So I've worked with an array of diagnoses, and I will tell you, joints have always been my favorite, always, 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 always. And I do tell people that who are on the X10. So it's a comfortable fit for me because even when we were in school and we were learning about joint replacements and watching the videos that you get to see if you've had a joint replacement, some of the surgeons, recommend that you watch a joint replacement. And from that moment, even on through after, I've just always been fascinated by them and how you can take something that doesn't work and put these new parts into it and rehab it, and it just completely changes your world, your quality of life, and, for the better. And so I've just always been fascinated by that. And so joints were already up my alley, and then this machine, the X10, anyway, so I just told her, I was like, if they ever need coaches, call me because I'm in.
So that was the transition from pre to eventually post learning about X10. Let's go into that a little bit more, though, about what you would do, before even hearing about this thing on the joint front with your patients. It's a long time, 16 years of working mostly in the home, it sounds like, doing joint work plus other stuff.
Right.
Let's go to a knee then. What was life like 5 years ago when you had a total knee replacement? You're in a home, you're a PTA, you're in a home care company. What is that like? What are you doing with those patients, and what kind of outcomes are you seeing?
So generally, when I would have a knee replacement patient, first couple of sessions, and I think that anybody listening who's maybe even been in home care will feel this way. And it's funny because Erin and I were just talking about this the other day. But the first couple of times that you're in somebody's home, you're giving just basic exercises, but more just being there. Kind of creating a relationship, because it has to be a trust. If somebody is coming into your home and you are not feeling well, right, which generally you're not, but you're not feeling well, there has to be compatibility and a level of trust. So the first couple of visits are always just pretty easy going. Let's see what you can do. Here's a few exercises that I want you to start. And generally by visit 3 to 5, I'm really amping people up, asking a little bit more of them, asking them to do more, starting to work on their gait patterning. And, if they're going to be eventually transitioning into outpatient, we eventually address stairs or getting in and out of the house, or, doing a car transfer. And, of course, working on the infamous range of motion, and, in our head, therapists, we know those goals that you have to reach. We know that, getting to 90 is critical, right? And then we also know beyond 90, you have to be somewhere between 110 and 115 to be functional, and then going beyond that, 130 is a healthy knee. So we will never, in home care, I rarely saw people past, I don't know. I mean, it has been a little while, and I'm getting older, but generally right around 105, you would have those people that really were able to push it and get further. But generally somewhere between 90 to 100 is when we would put them into outpatient, and I would have been with them for at least somewhere between 2 to 5 weeks, depending on what their doctor's protocol was, what insurance would cover. There's so many factors to that decision. But my 2-weekers never quite got that far. I do know that. Sure. They made all their gains in outpatient. And so transitioning your brain from that to the X10, I know it blows my mind every time, when we're working with patients. And some of them, day 4, they're at 0 and 90, day 5. And you're just thinking, oh my goodness, like this, it's not something that we would have typically seen in the home. And we're doing it on a very consistent basis. I mean, that's something that very, very, very consistently, people are getting to. And I mean, I'm sure that my supervisors in home care would have thought like I was some sort of superwoman, if I was doing that with my patients.
Right.
In the home. And like I said, not to say that people didn't get there. I'm sure, in my 11 and a half years that there were, but not enough that it made an impact on my brain, that I remember it.
Let me jump in and define a couple terms and clarify some things. One is when we're
Sure.
talking about the numbers, for those that are listening, we're talking about range of motion, extension, all the way straight is 0, and back where your calf is touching your thigh is about 130, and that's our ultimate goal for many, not everybody, but a lot of people want to get full function. And then the other person we keep referring to, but we haven't named, is Erin Rempher, and we've done an interview with Erin already, so you can go back and listen to an interview with, PTA Erin Rempher, if you like, and that's really the conduit through which Candice ended up at X10. So those are
you're lovely, Erin, who I say is, she is amazing. First off, she is an old soul. And, I'm older in the in the physical therapy world than she is. And that girl has a brain on her. And she remembers things that we learned in school. And she has re-educated me on so many things. And she is so smart with the machine. And she's amazing with the patients. She's gold. So
we're lucky. We've
got
Erin.
Yeah,
we've got you
we are.
too, by the way.
Well, of course, but
goes without saying. But let's say it anyway.
That goes without saying. Yeah, sorry.
But let's talk about now home care. How many patients would you be able to handle during a day or a week, however we define it, at any given time in home care? And then compare that to what you're doing now. I guess I want everyone to hear sort of that routine, which is like knees and elbows and all kinds of conditions, to your
stroke,
your world
and heart
now.
attacks.
Yeah. To compare those two things, if you could.
So in home, when I was a lot younger, and I was really working, sometimes I was seeing upwards of 8 patients a day, but that is starting at like 8 in the morning and finishing at 6, 7 at night, and that is, some people are pretty far apart. Comfortably, I liked about 5 patients a day. And that would be, typical, like I could maybe start at like 10 and be done around 4. But of course, it always depended. Home care is a variable that's always up and down, as is, I guess, everything. But so typically I would, in a typical week, anywhere between 5 and 6 patients a day. And since I've been coming to the X10, since I've come to the X10, I would say I like talking to my people more consistently if I can, even, if it's just touching base just through a text and saying, hey, how are you doing? But sometimes I'm talking to somewhere between 7 to 10 people a day. Most of them will be phone calls, and then there are the texts. It depends on where you are in the process, and how you're doing. I have some of my people they're very, very close to the end, and just a few days away from pickup, and generally they're very independent. A lot of the times they're now at the point where they're starting outpatient therapy, so they don't have the same kind of time and attention that we had at the very beginning when I could talk to them every single day and know right where they were going to be. So those that are more mobile and independent at the end, just be a text checking in, or when I see people hitting milestones like that 90 degrees, that 100, that 110, that 115, that 120, when we see those awesome milestones, that people are working towards, I do like to shoot out a text like, oh my gosh, you made it, congratulations, keep working, got more numbers to hit. But generally we'll do a session on the phone, and depending on the person, that can be anywhere from 15 minutes to an hour. It just depends on, the individual, and I get chatty sometimes.
Really?
And
one would never know that. Shocker.
I get chatty sometimes, and I love people. I love hearing people's. I've heard so many stories over the last 16 and a half years of this career that I'm in, and I hear some of the funniest, some things I don't know why people tell me and I probably shouldn't repeat, which I don't, but then also, amazing stories about, people and where they've come from and where they've gone. And so I love people. So, sometimes I'll just say, hey, while you're on the machine working on your range of motion and you need a distraction, tell me about yourself. And sometimes that turns into quite the conversation. So
I can imagine.
Yeah.
Are you doing much, Candice, on video, or are you really just using the phone?
You mean like FaceTiming?
Video call? Yeah, that kind of thing.
I think no. Most of my stuff is over the phone. I do, some house visits depending on, what's going on with people. And every once in a while, I will do a video chat. It's somebody that has to have, an iPhone or Skype and know how to work it, which
right.
Sometimes I'm not good at myself. So there are instances, yes, where I do. I just video chatted with somebody earlier this week because they had a question about elevating the leg, and I needed to see what they were doing, and so they were like, "Oh, we've got iPhone, we can FaceTime with you," and so I do that, and of course I do Skype. When you get the machine delivered, we Skype that day so we can say hello face to face. So we're not just a voice over the phone. Yeah, so.
What about the data that the machine is sharing with you? How does that change or affect the way you treat the patients? Because the machine, for those that don't know, most of you, there's a dashboard that every coach has access to, and it's got analytics and information that reveals a lot about what's going on in the home, on the machine, with the patient, in charge of that therapy. And you're able to see those sessions and then, kind of collaborate with the patient based upon that data. How does that affect your coaching?
Well, I'm going to clarify something just for those that don't understand is that we can't see it live. We do not see anything live. But within 10, I think Erin's told me it can actually be sooner, but within 10 to 15 minutes is what I tell most people. After you're done with the session, your X10 sends results over to our X10 results page. And so I can access it. So generally I start, my morning when I'm warming up the computer and stuff, and I'll just do a quick scan through everybody's range of motion numbers and, find those maybe that have hit a milestone that they've been working towards, or maybe a goal that the patient and I have set together, and I see that they have hit. I will also, because this is something that people deal with as well, there are people who, because of, other going on might be struggling a little bit. And so, keeping an eye on that, and, people who maybe need a little bit of an extra, an extra phone call to, so that we can talk about what's going on. And sometimes it's simple, sometimes it's not. So, so that's how we use that data that we see. Those that are prehabbing with us, I try and run through their dynamic strength program numbers and their concentric and their eccentric, which are two other programs, and, check all of the strengthening numbers and make sure everything is looking good and that you're doing it. Because, sometimes people that are prehabbing are really busy with life and things get away from them. So I like to make sure that we're still doing that, because that strengthening component for the prehab program it's really important because most people aren't strengthening before they go into surgery, and it's a really important part of what the X10 has to offer. So there's a number of things, that we definitely, I'm constantly jumping back and forth when I'm talking with people during a session. I'm constantly jumping back and forth between, what I'm writing and popping into their numbers, looking at previous range of motion numbers, looking at strengthening numbers. If people are getting ready to do strengthening for the first time post-surgery, I will pull up, if they prehabbed with us, I'll pull up those prehab numbers so that we can see what they got, before they got off of the X10 and, to compare to how they're doing, first time through. So that, I think, is one of the things that is so amazing about the X10, not besides the fact, when you were just talking about it and explaining it, it's providing consistent feedback to the patient through, the screen that they get to watch, constant feedback. Patients, and once you really start to understand the machine, and, patients will, they're reading the numbers, they're like, oh, hey, I used less of this to get to this, or, oh, wow, I got a couple more numbers, and it's just that constant feedback, which can be very positive, and then it bounces over into our stuff so that we, can know where people need help or a little bit of encouragement or what their next goal needs to be. So quite an amazing, just the whole thing.
And, it's so interesting to hear you speak about this. You speak so well about it. Obviously, you're living it, breathing it every day. But it's a collaboration. The data is there. The patient's got real time. You're delayed a little bit. But it's, that doesn't seem to get in the way of the fact that you're both really on the same page every day with your calls, and you're working together. It's almost like there are three of you. You, the patient, and the machine, all working in collaboration with one another. The device providing insight on its own and advice to the patient on its own with its little blue arrow saying, hold it, don't go anywhere, or, yep, I think we're ready to go to the next degree. Strengthening, eccentric, concentric, hamstring, neuromuscular re-education, But I guess where I was headed with all that is, and I've never spoken with a coach, I don't think, about this, at least on a podcast recording, and that is, what are the other techniques? Let's say you've got a patient that's 5 degrees short of where you want to be, and let's call it flexion, the usual suspects, right? The usual problem is bending your knee back, and we want them to bend at least 110, 115 before, they're released into the wild or into. What are the other things that you do, the other techniques beyond the range of motion program itself that you're doing, or maybe as part of that program that you're doing with the patients to sort of inch that knee back for flexion? Or what are the little tricks that you've got?
So one of the big tricks, which again is compliments of Erin and her brain, but something that I'm very familiar with from my years in therapy, is we typically, if we're trying to get a few more degrees out of you in flexion, we use a technique. It's called contract relax. And if anybody has been out in the therapy world, out in outpatient, or even home care, right? It's something that you might be familiar with, but it's something that we use to fatigue that muscle, because sometimes if we can fatigue the muscle and we get rid of that last bit of muscle guarding, sometimes you can gain a degree or two. And once we get that degree or two and we've opened the joint and we've stretched the ligaments, we can go back there because, the X10 is going to bring it back. And so you're going to get a few times in that new range, say maybe you were at 125 and you're trying to get 130, and, we get you to 126, 27, and then it holds you there a few times. It stretches the capsule and the tendons and the ligaments around it so that we kind of solidify. It's a word I use a lot with my patients. I'm like, we've got to get this range, and we got to keep staying here because we really got to solidify this range, because when you have solidified it, it means that is a solid range that you can now move past. That we know that you can get to 110. You've gone to it. You've solidified it. You're now getting past it. So we know that you can get to 110. And so we do. We use that contract relax There's other things, other techniques. There's, I hate this word, reciprocal.
You did so well.
Oh,
reciprocal.
I don't like that word. I think it's inhibition, reciprocal inhibition. Right. And if Erin's listening, I'm sure she'll laugh if I'm saying it wrong. But but there's a couple of other techniques. We get patients who do struggle with extension. It is not as often, but I mean, there are those people out there. They just like to, keep us challenged, which is good for us. And, we can use the machine, to do extended, stretches. There's lots of studies out there, lots and lots and lots of studies, where you can see that sustained stretching causes flexibility. And that's what we need. We need that flexibility. Your knee needs to go to zero, because when you walk, that affects your gait. And getting to zero, getting to a true zero, which again, if you work with us, you would get to hear. We always talk about, we got to see if you're at a true zero. And doing quad sets with the leg out straight. At that zero, we do quad sets to push down, because there's nothing under the knee, to push down into that zero, that we're really solidifying it, because when you're walking, you need that terminal knee extension, for that gait pattern to be good, so that we don't, have any other issues. So those are a couple of the techniques that we use.
Quad sets, reciprocal inhibition, contract, relax, and you're doing those on the machine as part of the motion or the activity of the machine. And then, you are getting patients sometimes that go 3 or 4 weeks. Some are covered by Blue Cross Blue Shield. Others are renting it for an extra week or two. Most people can get the job done in 14 to 17 days post-surgery, but, there are obviously all kinds of situations.
Sure.
How much of the strengthening are you getting to, and what are people doing to stop atrophy and maybe even start to make some strength gains again after surgery? What are those activities? So
post-surgery, most patients, a lot of the doctors will have already, I think that it's more rare for people listening. If you're having an outpatient procedure, because there's all different kinds, they now, just the direction that joint replacements have gone since, I started 16 years ago, and people used to stay in the hospital for 5 days, to now they do them outpatient. Like, people have the surgery and they go home a few hours later. It's amazing to me, how far things have come. But generally when you're outpatient, you don't get this. But if you're at least 1 to 2 days in the hospital, they'll have a physical therapist or an OT come in. They work with you on walking. They've gone up and down the steps with you, and they've actually left an exercise program with you. Some of those doctors that do outpatient surgery, they'll actually have like a packet, right? And inside the packet there will be some of the just very basic generic exercises that they want you to get started on before, a lot of people have home care, so before home care can come in. So a lot of patients will be doing those exercises, just to start helping to refire the muscles, to get things going again, because, I tell this to my patients all the time. I know that this is an elective procedure, but it's still a traumatic. It's considered, a traumatic surgery, because there's a lot going on, and it affects the muscles and the nerves and everything around. And then one of the things that we do with the X10, somewhere between day, I don't know, I generally do somewhere between day 2 to 4, is we do the pump and we do the calf. And they have a strengthening component to them, but the beauty of those two exercises is that one of their jobs is also muscle pumping, which helps, pull some of that swelling and can help with the swelling reduction. And so it's kind of a 2-for-1er. And so, we'll be doing, we won't. The patient will be doing the exercises off the machine, that their doctor or their hospital PT gave them. And then we're doing, some of that stuff on the machine, which, contracts all of those muscles. And I've had patients who have had a hard time firing their quad in the pump test, because we're using so many muscles at once, have helped bring that quad muscle back. And Amongst other things, but it's one of the things that really, it helps. So,
can you explain that those two activities, the calf and the pumps, for people that have not sort of laid eyes on the machine?
Sure, yeah. The pump test is, we have 2 rollers and a foot plate, and your feet are between the rollers. And another piece to this whole puzzle is the amazing, I call it the arm of the machine. I think some of the other coaches do as well. And that arm of the machine, the foot plate, the front roller, the back roller, have sensors in them. And it's how this machine is so sensitive to everything that you do, and how it provides you feedback, us feedback, how it protects you, how it keeps this, it's not going to be completely pain-free, but how it keeps it somewhat, in control, because it's so sensitive to what you're doing. But with your feet between the foot rollers and obviously your foot set on that foot plate, the pump test is done by pushing down, contracting every muscle in that leg from, the calf, which is 2 parts, but from the calf to the quad, to the hamstring, to the IT band, every single muscle that's in that leg, because you're pushing down into that foot plate, contracting everything, and then relaxing. So I tell my patients, when I describe it, a very good visual is that when you're pushing down into that foot plate and you're holding all of those muscles really tight, and then you relax, because it's a 30-second cycle. So you do them for as many as you can for 30 seconds, but we have you do a 2-second hold, really squeezing all those muscles and relaxing. I tell people to visualize a sponge, and if you have a sponge filled with water and you squeeze and twist it, what's going to happen? That stuff's going to come out. And
right.
So, by pushing down and contracting all of those muscles and then relaxing, we're pulling the fluid from them, right? And then your system, picks up that fluid and hopefully wastes it out. Of course, there's all different scenarios, and sometimes it does not happen right away, but it definitely helps the process. So that's the pump. And then the calf exercise is done. The arm will go, again, the arm of the machine will go out straight, and your foot goes on that foot plate under that bottom roller, and you're pushing down through your toes. So we're focusing solely on that calf muscle. So by pushing down and activating the calf muscle, again, we're doing muscle pumping, because we're tightening that muscle for 2 to 3 seconds and relaxing on a 30-second cycle. So you're doing as many as you can on that 30-second cycle. And I think, honestly, people get generally somewhere between 5 to 7 reps done. And we also, by muscle pumping the calf, we decrease the risk of blood clots, because we keep things moving down there. And that one is, got a dual to it, where we're not just muscle pumping, but we're hopefully, decreasing the risk of blood clots, which, people with this surgery run a big risk of, because, you tend to be a little bit more sedentary because it hurts to move. And I always tell people, you know what, I know it hurts to move. We got to get up and get on the machine, because it feels better when you do. That joint, in order to heal, has to move.
It's amazing how it can feel good. I hear that from people. It feels good. Whereas, usually everybody dreads physical therapy. I mean, who wants to, hey, let's go to PT, how much fun that's going to be. But in this case, and I don't want to describe it as fun, but you do have dials and screens, and you've got goals, and it's a little bit of a game, and you've got Candice and, a plan, and you're doing it at home in the peace of your home, and you're doing it 3 times a day, not once a day, which is, in your past life, your visit is shorter, right?
Right. But let's be real, though, that you saying once a day, no, if you get home care, and of course it's the world that I came from, or outpatient, you're only getting it maybe 2 to 3 days a week. The X10 in your home, you're doing it 3 times a day. I mean, that right there is huge, And of course, when people come into your home, they do leave exercises, and I expect that you're going to get on the X10. When I did home care and I left you exercises, your recovery is up to you. How you choose to do, how much you choose to do or don't do, is on you, and that makes your level of recovery also on you. But how much easier is it to get on the machine and let something else range your leg for you while you just push buttons? You know what I mean? I have found people's level of compliancy with the X10 far outweighs, I guess I should say, what I had as far as compliancy in home care. You know, people.
I think you invented a word. I think you've
outseed. I invent all sorts of words, don't I?
I like that. That was it. Not exceeds or outdoes.
Outweighs. I can't play Scrabble because my husband won't play Scrabble with me because I make up words.
Right.
So,
you're a nightmare. Scrabble nightmare.
I am. I come up with all sorts of just craziness. It's me. It's me. Anyway.
So one more. Let me go. I'm sorry. Did you have another thought on that? I don't want to interrupt your.
No. I had finished. Just in the sense of, you know, that I have found that follow through is just a lot better. And I think that is why Erin and I talk about this all the time, because Erin came from the home care world as well. And the expectations for patients on the X10 are so much greater, but it's because we know what they can do with it and how much further ahead they can get with it because they're doing it 3 times a day, and it's doing the work for them until we get to the strengthening aspect of it. For anybody that's listening and they've done it, probably thinking that in your head, right? But as far as the range of motion program, which that range of motion is vital. If you don't have your range of motion, it doesn't matter how strong you are,
right.
You know. So you know, that range of motion, is so important. Yeah. And you just sit there and you just push a button. Like, hey, I want to go to, 100 today. Oh, give me a little bit more pressure to get there. That's great. I'm going to go to 0 again. And we're constantly changing that warm-up range of motion so that we're constantly pushing into those bigger ranges. So I went off on a slight tangent there. See, you opened the floor, and that's what happened.
I did. I let you out there, and you're going to just run.
You did.
And meanwhile, you wrote our next slogan, and everyone heard it live, X10 Expectations. That was right here. Copyright by Candice. Trademark immediately. Hashtag X10 Expectations. That's a great concept, Candice.
Really well, Erin and I talk all the time about, X10 Expectations. If you're listening to this and you've been a patient of Erin and mine, and we chat all the time and go back and forth, and that's a constant thing. The X10 expectations are so much higher than what we would have expected out of a patient in their home getting home care. So
let's bring it home clinically, and then we'll bring it home for our interview. You've done all the pumping, the pushing and pulling, and you've done passive and active, and your session is done. What is your recommendation on icing and elevation? What kind of parameters do you put on that? Well,
first off, it is important, and I always try and put it into terms that make sense for people. So you've just got done range of motion, doing the range of motion, right? Some of you, if you're far enough ahead, you've done muscle pumping, for the calf and the pump. If you're far enough ahead, in your recovery, then we started testing your quads and your hamstrings, or doing that concentric and eccentric program, and so we've gotten everything moving. We've gotten fluid. Kind of a yucky word. We've gotten fluid moving. We've got stuff going. Your system is trying to pull all that junk and waste it out so that it can come out of that area. And so I tell people, like, we've opened the highways, and all of that fluid is coming and going, right? So we ice and elevate so that we close it down. And so we, make that hole so small, that it can't come through. So icing and elevating is a very important part of the whole thing as a picture, right? And for those of you that will have me or have me, I do try and include, any exercises that your therapist has given you that you do actually right before you get on the X10. And there's always a method to my madness. We do those exercises, then we get on the X10, and we do everything on the X10, because then we immediately ice and elevate afterwards. Because it's a nice flow and it makes sense, because we're going to wrap everything up in ice and elevate instead of trying to get up and do something else. Because the X10 will pull the fluid better than anything that you're going to do exercise-wise. You know, the exercise is strengthening, and the X10 is ranging and moving that fluid out, which is what we want. And so once we're done with the X10, we want to close that. So ice and elevate.
Length of time? Yeah. Is there any magical? Go ahead.
Generally people will go from anywhere from 20 to 30 minutes. For those of you that are Googlers, there's a lot of studies out there of, what scientifically, what's the max amount you can heat or ice and all that kind of stuff. But generally I tell people 20 to 30 minutes. I will also tell my people, if you don't have an ice man that encases the whole knee and you just have the ice packs, 10 minutes on the top of the knee, 10 minutes on the bottom of the knee, or if you have enough ice packs, do them both at once, because I think sometimes the back of the knee gets forgotten and it's still a part of the surgical area. You know what I mean? And so I'll have people that are like, oh, the back of my knee is so swollen. I'm like, well, we got to be icing that. Or, even the ankles or the calf. I mean, people get swelling all over. Our systems are all different. We're all different, and we're all made differently. We heal differently. And but I like for the elevation to be above the heart. So lying flat, which I know is boring, right? But lying flat with that leg elevated above the heart. And the whole purpose to that, in case people didn't know, is because then gravity is doing the work for your heart, and your heart's not having to work as hard to pull that fluid, to pump that fluid from the leg into your system so that your body can waste it out. So, we want that elevation because we don't want your heart to work as hard, because if it's too much work, it's only going to do so much, and then you just basically sat with the leg elevated. I don't want to say for nothing, but for very minimal. So it is best, to if you can lie flat, and then stuff doesn't pool up in the hip area and, and through your pelvic area, and that way it can get through more clearly. And I will tell you, and I have been discovering this, you do not want to over ice with an ice man. If you have ice packs, the same thing doesn't happen. With ice packs, the ice packs cool, and so it's not that big of a deal. But if you have an ice man, you do not want to go beyond the recommendation that is in those discharge paperworks from your doctor, which is 20 to 30 minutes every hour, right? Because you can actually cool the component inside your knee down. And I had this with a patient. It was the craziest thing. And her whole leg ached. And come to find out, she was over icing. And she had gotten that component cold, and it was creating a bone ache. And after 24 hours, of icing the correct way, that ache went away, and she never had it again.
Interesting.
So that's a nope. And I had heard it. It just, I had never been in a situation where it had happened. So I do try and tell my people, if you have an ice man or one of the compression icers, really stick to the directions. I know the ice feels good to most people after surgery because it cools that knee down that is so warm. But you really want to stay within the parameters of the directions that your physician or the people that have provided the ice machine to you have given you, because there's a reason for it.
I heard another thing that I'd never heard about, the actual implant cooling, but I have heard this. I wonder what your opinion is of overcooling to the point where the body feels cold and sends in fluids to warm it up, completely contrary to what we're trying to do. Have you ever heard that thought?
I'm sure sometime that I have. I have not thought about that in a while, but yeah, you're right. You're right. That could be another component, that if you over ice, that could possibly happen. I'll have to actually,
at least.
I will have to look into that. You're giving me homework now, PJ.
Homework. I love it. And when you're lying on your back, though, and your leg is up, what a great occasion to listen to the Bees Knees podcast. Well, there you are.
So
30
amazing.
Minutes to burn. Just listen to us.
Just one right after the other. You can listen to this one multiple times, because I am included in this. And
oh, God, the ego.
My soothing voice, you just want to hear it over and over and over.
Sing-song.
That's right.
Sing-song voice, yeah. Wow, well, this has been fun. Did we miss anything, Candice, that you want to bring up, though? This has been, honestly, to be honest,
Well,
I got to say, I did not expect we were going to be as clinical, and I love that we went there. It was kind of like, well, let's get to know Candice, and boy, have we covered some very important ground, really in particular for people that are for sure going to be on the X10. I mean, I really want them to all hear your voice. And for those that, may never need us and, or may their future's far down the path, it's good food for thought, at least,
Always. We can always learn something new. It's what keeps us mentally young, right?
Right. But wait, did we miss anything that you want to bring up?
Well, PJ, I always tell my people, I can always find things to talk about. So we don't want to open that ground because I can go on and on forever and ever. But I think that we covered, without going into other things in detail, we got to save something. Maybe you'll invite me again later, and we got to save something for later, maybe.
And I think we could do some clinical work too, and talk about some very specific topics. And we'll do that. We'll do this. So
but I think that we've basically covered all of the ins and outs, and the bones, so to speak, without being which totally makes sense, doesn't it? Bones and bones. Oh my goodness.
Bones. Well, thank you so much for sitting with me and talking on this little production. And I know that it's been instructive for me. It's been great to listen to you, and I know that a lot of people will really benefit. So thank you for being here.
Oh, well, thank you for inviting me. Everybody, thank you for listening. I'm honored, and hopefully I get to do it again sometime.
Yay. Yeah.
Yay. Okay.
I told you. Wasn't that great? Neat lady and very smart about this whole recovery business. She's a valuable addition to our team at X10 Therapy. I'm really glad that we got a chance to sit down and talk and that you got a chance to hear that. So thanks for listening, and looking forward to our next conversation. See ya.
We'd like to thank a few friends of the Bee's Knees podcast, including the Knee Pain Guru, natural solutions for chronic knee pain without drugs, shots, surgery, or painful physical therapy. For more info, visit thekneepainguru.com. We're also brought to you by X10 Therapy. And special thanks to Dr. Justin Trosclair at the podcast, A Doctor's Perspective Podcast.
I'm Dr. Justin Trosclair, host of two-time Podcast Awards nominated A Doctor's Perspective Podcast. I interview doctors in and out of my profession about their specialties and the occasional non-doctor special guests. But we also go behind the curtain and see what's working for their marketing, overcoming struggles, practical knowledge, book choices, and relationship advice. Join me on any podcast app on your phone, or visit adoctorsperspective.net for the show notes pages and free resources. I want you to have an abundant home life as well as a thriving practice. So come on, take a listen.
The Bee's Knees podcast comes to you from our studio in Lower Manhattan, New York City. We're here week in and week out, shedding light on all aspects of knee surgery and recovery. To reach us, send an email to thebeeskneespodcast@gmail.com.